Good afternoon, everyone. I don't know if you can see me or if you're looking at that, but my name is George Cheng Chen, and I'm a physiatrist located here in sunny Southern California. Thank you for joining us. We have almost 200 people signed up for this webinar, so very grateful to have you all, people who have signed up from all over the world. I'm a physiatrist, and I specialize in comprehensive pain management. We have a fantastic speaker with us today. I have the distinct pleasure of moderating this session, discussing approaches to optimize intradiscal injections. And we have my good friend and my professor, my mentor, my professional father, Professor Sudhir Diwan, who's joining us out of his beautiful home and office in New York and New Jersey. Before we fully introduce him, though, and get started with this programming, I'd like to take a few minutes or 1 minute to thank our sponsor for this program, Apex Biologics. And they're going to play a short video clip regarding some of the products that they have in their lineup.
There's no video clip.
All right, just kidding. There is no video clip. Okay, well, so for those of you who don't know Sudhir Diwan, he is an incredible educator. He has written multiple books, dozens, if not hundreds of manuscripts, really focusing on optimizing interventional pain procedures. And so it's so fitting for him to be giving us this talk on regenerative therapies for disc injections. Professor Diwan, please, by all means, take it.
Thank you so much, George. This is wonderful to see you after a long break, and thank you for kind introduction. You've been always so generous introducing me to. It's my pleasure to be here and be part of this webinar that is sponsored by Army. And today we are going to talk about the intradiscal injections, the technical aspects, and how we can optimize and maximize the outcome. Let me know if there is any problem with the slide viewing. So these are my the conflicts of interest. I am a faculty for Army and occasionally take part into courses like this. So let's start with understanding why we should really do regenerative medicine. And when we do regenerative medicine, we have two distinct goals. One goal is to really have a symptomatic relief, which is a short-term goal. And the second goal is the long-term goal, which is kind of very important for us because we want to stop the progress of degeneration of the disc and also provide some regeneration to improve the health of the disc. So we have short-term goals and we have long-term goals. And also, let's understand some basics of disc injections. Whenever we plan to do the disc injection, we have to understand what specific reason why we are injecting. Is it for only degenerative disc disease, or there is a herniated disc with some radicular pain, or it's a combination of everything? There's some herniated disc, some degeneration, and a mixed picture. We also have to understand that each disc is different. Cervical discs are different than thoracic different from lumbar, and also the degenerative discs are different than healthy discs. So each disc is different, and we need, when we plan the disc injection, we really have to identify the specific disc for a specific reason. And for that, the discogram is very, very helpful. I do discogram in almost every patient. If I'm planning to do PRP, you can do discogram on table, but if you are planning to do a mesenchymal stem cells, then discogram has to be done a couple of weeks earlier, not at the same time. And the most important is where to inject. Just injecting in the disc may not serve your purpose, because as we discussed, we have two goals. One is for the symptomatic relief, and second is to stop the progress of degeneration and called regeneration. And for that purpose, we need to inject biologics into different location. And that is intradiscal or peridiscal or intraannular, where the tear is. With that, I would also like you to understand this slide. In this, you have a disc that shows the degeneration, which is in the center, and then there is inflammation, which is in the periphery. In other words, whenever you plan to do the injection for degeneration, that has to be the center of the disc. That's what we call intradiscal injection. But whenever you are also planning to do the symptomatic relief, then you have to inject the peridiscal area because this is where the inflammation is. So the central and peridiscal area, and also if you are planning to do an annular tear, then it has to be intraannular. This is a short list of the biologics we use. The acellular therapy, not really that common practice as of yet. Exosomes has been used, but has not been used for disc in the spine, has been used for musculoskeletal conditions. A2M is alpha-2 macroglobulin, is very important, mostly for the joints because it preserves the health of the cartilage. It prevents the breakdown because it is broad spectrum protease inhibitor. The high density collagen is still, and intradiscal fibrin are still the research products has not been used in the clinical practice yet. The cellular products are, of course, an autologous PRP, but autologous stem cells, either derived from the bone marrow or adipose tissue, has been in a regular practice. Autologous laboratory expanded stem cells, where they take out the cells from your own disc, then send to a lab and expand them in a lab, and then re-inject, and those are your own cells. You can have allogenic adult stem cells or allogenic embryonic stem cells. Now, embryonic stem cells are pluripotent cells, gives rise to ectoderm, endoderm, and mesoderm. And the adult stem cells are more like multipotent cells, which has less cell differentiation than embryonic stem cell. The IPS, the induced pluripotent cells, are very important concept. It hasn't been practiced yet, but once we have this IPS, I think it would be very interesting because you can actually convert into your own somatic cells into embryonic stem cells. Just a few slides regarding the product that we use. We are using either bone marrow or PRP, and we are using the spin systems. It could be a double spin or single spin. Double spin actually helps you to separate the cellular components and gives you, and double spin gives you a buffy coat of either PRP or bone marrow concentration. But most important also is to understand it also gives you plasma, which is rich in proteins, which are the scaffolding proteins. There are some couple of examples for the double spin gravitational systems, and that we have so many systems available. So you really have to understand system, how it works, and what kind of products you get. And the system that gives you, double spin system that gives you a buffy coat, and the top portion of the platelet poor plasma, which is actually very important. You cannot afford to throw it away because this protein has all the matrix building proteins, fibronectin, fibrinogen, vitronectin, but also it makes the product anti-inflammatory based on the ratio of the interleukin receptor antagonist. So it's very, very important. And it also has alpha-2 macroglobulin. Now, alpha-2 macroglobulin, you can either use the recombinant product commercially available. And if you want to use your own alpha-2 macroglobulin, you can use this concentrating system, and then gives you a higher concentration of A2M. The problem is this is not a very cost-effective process because the system will cost you $600. It takes 20 to 25 minutes to get the concentrated volume. And so most people will not use the system, but you can use it and then mix it with the buffy coat of the PRP or the mesenchymal stem cells, and you have the best product. There are some single spin systems are available called ACP, the autologous conditioned plasma. Here, there is no buffy coat. It only gives you the plasma and separates all the blood cells. So there is no buffy coat, there is no PPP. The disadvantage is the platelet count is very, very low. The advantage is you have the protein fill all the plasma that you can use it for your injections. And also other advantages, if you have lower platelet count, automatically that will also give you a leukocyte poor PRP, which is kind of most people like who use for the spine. But keep in mind that low platelet concentration may not be the best product for your patient. There are some studies that have come out and they focus on a concentration of intrathecal PRP. These two studies, and specifically LURT study, they talked about when the PRP concentration was less than 5 times the peripheral blood compared to more than 10 times peripheral blood PRP. The outcome was much better and the satisfaction rate was much higher. So we still need more study, but there are some indication that the higher count of the platelet may be beneficial, but the product has to have everything, the acceptable high PRP, but also give us plasma proteins that we need for scaffolding and for other purposes. The other very important product that we use is the mesenchymal stem cells, and it is very popular because it has the ability to differentiate into different kind of cells. But also another very important property that mesenchymal stem cells has is called paracrine secretion. It secretes the small vesicles, microvesicles, and exosomes, which are actually supposed to be steering the regenerative process, especially exosomes. And so, though not yet the mainstream practice, but exosome down the road may be very important component of the our injections to use and promote the regeneration of the tissue. The other very important thing that we need to know is cellular analysis, cellular count. These two studies, Kenneth Patin's studies, told us that the total nucleated count more than 120 million would be better with the CFU or 2,700. He also looked at the CD34 count, which is close to 2 million. CD34 is the marker for endothelial and hematopoietic stem cells, which are very, very important for the products, blood products. So the CFU count is very important, but then Sairam study also looked at the TNC, and his study showed actually much higher number of the total nucleated count, which are the precursors compared to Kenneth Patin's study, and it also had a higher number of the CFU. So to maximize the cell count and to maximize the best product, you also have to learn where to take the bone marrow from. The posterior superior iliac spine is the best place to draw the bone marrow. In this particular, the yellow dots are where the bone plate is very thin, so try not to go in there. But this 5 and 6 area, mostly the 6 area, is very common for the bone marrow aspiration. And the other thing, to optimize the bone marrow aspiration, you also have to learn some of the technique, rapid versus slow aspiration. Rapid technique will give you better pericytes, which are the mesenchymal stem cell residing in the subcortical area. If you do a slow aspiration, it also draws the peripheral blood that is in the sinusoids of bone marrow, and that dilutes your bone marrow. So a rapid technique is preferable. Single versus multiple insertion studies I've done, there is no different into the cellular products, but the multiple insertion will be more painful than a single insertion. So I like to do single insertion. I rotate my needle and advance 2 millimeter every few aspirations. Then the third very important component is the small volume versus small syringe and small syringe. So if you have used 5 cc to 10 cc syringe, and if you aspirate 1 to 4 ml of blood, the rather bone marrow, it will give you a better product. In this table, you can see different sizes of 10 cc versus 50 cc and different volume of blood and what is the difference of the cellular component. So the bone marrow component have a buffy coat that gives you hemopoietic stem cells, mesenchymal stem cells, adult and precursor T and B cell, concentrated platelets. This is very important concept because initially people used to take the PRP from the peripheral blood and then mix it with bone marrow. However, platelets are manufactured in bone marrow. There is enough platelet concentration in bone marrow, so there is no need to add extra PRP. It also has all the scaffolding proteins A2M. There also IREP, the interleukin-1 receptor antagonist protein that actually makes the product anti-inflammatory based on the ratio. And bone marrow concentrate is a little more anti-inflammatory than PRP. In other words, the PRP might give some pain because of the inflammation in the beginning, compared to bone marrow injection that does not that does give, but not as bad as the PRP. And it also has bone morphogenic protein for bone growth. The very important thing about now is when you do the bone marrow aspiration, it is very important to really maintain the strict sterile condition. There are many areas there is a breach can happen and can cause infection. One is when you aspirate it, then you transfer to the syringes, then you will take the syringes to your spinner where you spin, single spin, double spin, so 2 spin. Then you aspirate the buffy cord and then you inject. So there are multiple steps. There are possibility of breach into sterility. So follow very, very strict sterile discipline. Proper prepping, draping. You can see this picture, on the top. I took it from the website, and it's like somebody's taking the bone marrow from the hip. No preps, no drapes, no guided techniques. So these are very important because when you do this, your fluoroscope should be draped. Your operating table is properly prepped and draped, and you should be properly attired with mask, cap, and gown to prevent the infection. The another very important is to follow the protocol for intradiscal injections. This is also, you may not find everybody agrees on the same thing, but this is what I do. And I'm doing disc injection for nearly 25 years and the discography injections and other procedures. But for disc injection for biologics, I'm doing since 2015, and I never had any infection. This is my standard protocol. Again, a very strict sterile condition, full prepping, draping of the operating table and the patient and the fluoroscope. I use dual intravenous prophylaxis, cefazolin and gentamicin 20 minutes before you start the procedure. And this is I do all the time. It covers almost all the bacteria. I do not put anything intradiscal. I don't think it's necessary. I had never done that. There are some physicians very strongly believe that intradiscal injection prevents infection. I think that is extra step to do that. And whenever you do any extra step, which may not be necessary, you are taking the chance of inserting the injection. So I never put anything intradiscally. And always use needle-in-needle technique. And here you can see in the picture, I have prepared my own kit where it is regular 18-gauge needle. Through that, I pass the 22-gauge spinal needle, and I perform this procedure, and this is all the time I do. So needle-in-needle technique is very important to really do to prevent injection. Again, stop and set as aspirin just to don't have anything that can cause the anti-inflammation, because inflammatory process is normal for this type of injections. And again, avoid steroid injection at least for 2 weeks before and for 3 to 4 weeks after. As I said, and anything that prevents inflammation may not be a good idea to use it whenever you use biologics, because biologics actually causes the inflammation to promote the regeneration. Now, discography before PRP and or mesenchymal stem cells, and it is very important. As I said, I always do it, and that is important to decide where to inject, because as I said, either intradiscal, intraannular, or peridiscal, to decide that the discogram is important. Also, how much pressure to apply to inject, because if there is annular tear, and if you use a large pressure injection and quick procedure, then you may actually, all the biologics might diffuse out of the disc through the annular tear. So to decide that opening pressure and how much pressure to use is very important, and for the discogram. Another thing, other important information you get from discogram is how much to inject, because degenerative discs are usually a very low pressure disc. They are very dry discs. They are very small discs. The height of the disc is very, very low. So that does help us to decide the volume of the biologics when we inject. Defining the annular tear, especially the complete tear, is very important, because if you, as I said, if you use a large pressure when injecting, you might lose all the biologics in the epidural space. There are some high pressure discs. High pressure discs are usually normal discs. That means when you put the manometer needle and connect to manometer, there would be very high pressure. That high pressure is around 30 to 35 psi, which is kind of normal. But that tells you that high pressure will not or may not let you inject any biologics intradiscal. So that pressure is also very important to know, and discogram can help you. The discography can be done at the same time if you are planning to do injection of PRP, but do not do if you are planning to do mesenchymal stem cell injection, because the contrast has been shown to be detrimental to the stem cells. Now, indication, there are no really standard indication that had been published and contraindication. For me, since I started doing this, I do almost all kinds of disc, whether it's a degenerated, whether degeneration with herniation, degeneration with radiculopathy. Every disc with the tear, I use it. When to use it is also very it's a matter of debate. But for me, if you are planning to do, or rather your long-term goal is to really reverse the degeneration or stop the progress of degeneration, then sooner the better. And the studies have shown that if you use the biologics for younger patient with the better disc, you have a better results than the when you wait till disc is almost gone and there is a bone on bone. Also, the lumbar disc has slightly lower benefit than the cervical disc, and that's because of the continued weight-bearing burden on the lumbar spine. So even if you do biologics intradiscal, the outcome is slightly better in the cervical disc versus the lumbar disc. The post-surgical disc, I have done a few where patient would go for the hernia, the microdiscectomy or endoscopic discectomy, and then will come to my office for intradiscal injection and intraannular injection. There is a surgeon in Cornell who actually does a tubular, he doesn't do endoscopic, but he puts the tubular retraction that goes right where the herniation is. And after removing the herniated piece of disc, he uses the bone marrow concentrate and injects into the annular tear right there. I think that is better than not doing anything, because if you don't really address that annular tear, the reherniation after microdiscectomy is 25% chances, and 50% of that 25% is actually symptomatic. So unless you also use or rather address the annular tear issue, the herniated disc may happen again. So lumbar disc injection, there are very narrow discs, so you have to really consider your volume. You can see these are my initial patients. They would come late. One of the patient has autofusion at L4-5, L3-4, and the L5-S1. And there was one slight disc was L4-5. So you can see how bad the disc is, very rarely you can get into the disc. So the volume would be injected, volume of the injected would be very, very low. The pressure is very low, so you have to use very low pressure while injecting. And if there is a radial tear, again, it might get into the into the epidural space. I always inject the peridiscal injection because all the symptoms are actually coming from the peridiscal area. And so make sure that you inject the peridiscal injection. The volume I consider is 1.5 to 2 ml for intradiscal injection. Intra-annular injection is very, very tricky. Never inject more than 0.2 to 0.25 because the fibers of the annular fibers are very tightly packed, and if you use force while injecting, you might disrupt the annular fiber. So don't use too much force and don't use too much volume. And then when the needle is out in a peridiscal area that you see on a fluoroscope, then use 1.1 to 1.5 in a peridiscal area. Now, injection for herniated with the isolated herniated disc or herniated disc with the degeneration, I have done many, and it's very tricky. And it's I want you to understand some of the very important concepts. One is that whenever patient has herniated, especially bulging and not frank tear, that bulging actually can get bigger and patient symptoms may worsen. So always tell the patient that you have herniated disc, bulging disc, and you are trying to inject some volume into the disc. They may worsen the symptoms. It does get better in a few days to 1 week. But if you don't tell the patient and the pain increases, patient might feel that you have done something wrong. Always go ipsilateral needle entry to the side of radicular symptoms. That also gives you the ability to go close to the annular tear. The intradiscal injection is depending on the intradiscal opening pressure. Do not inject under high pressure. Withdraw the needle into the annulus and with the pressure on the plunger, and inject into the annular tear when pressure drops down. And when you come to the annular tear, the pressure will drop down, and then you can inject 0.2 to 0.25 very slowly. And then the needle comes out, look into your fluoroscope. When needle is in the peridiscal area, inject another 1 to 2 ml of the biologics into peridiscal area. The injection for annular tear, there are a few things I want you to understand, because annular tear is always inflammatory and always painful, because this is where pain is coming from. But whenever there is inflammation, there are cytokines, and inflammatory cytokines actually may impede the repair when you inject the biologics. So you have to keep in mind that sometimes, effect may not be as you were expecting. Second thing, very important, is the volume is very, very limited, but even that limited volume may diffuse into the disc or may diffuse extradiscal. So may not even stay where the disc annular tear is. So less volume and very, very slow procedure and very low pressure is the best way to maximize that your biologic stays where the tear is. And more likely than not, it will aggravate the symptoms. When the tear or bulging is posterior, it is always challenging. So I use the curved needle and try to go close as close as where the tear is and try to inject. It may be into the nucleus pulposus, but maybe very close to where the tear is. So there are chances that you may be able to inject some biologics where the annular tear is. The cervical disc injections are very important, very low volume disc, the low pressure disc. Degenerative disc disease is less common as compared to lumbar. The injection criteria is pretty much the same. The volume should not be more than 0.5 to 0.75. It's a very low volume disc. And I always go on the right side because of the vital structure on the left side. But if your right side is not available, make sure you use the ultrasound. Even if you want to do under fluoroscopic guided on the left side, ultrasound is necessary for left-sided disc entry. Cervical disc injections require a little bit of understanding and some experience, and starting from patient position to how to access the disc. Fluoroscopic views are very, very important into craniocaudal direction, and sometimes slightly oblique. There are a couple of approaches are described in the books. I use both. This is called midline approach, where you apply the pressure between the trachea and the sternocleidomastoid muscle. Then you put the needle and you pull the sternocleidomastoid laterally, and just try to go into the disc, into the center. So if you can see here, the needle is placed some 20-40 degree angle, and then slowly put the needle into the disc. Once you pierce the annular fibers, you think the needle is into the disc, you turn the fluoroscope in a lateral and advance your needle only in a lateral view, because otherwise you might go through into the spinal canal and spinal cord. The lateral approach has been also very important. You just have to learn to use your fluoroscopic guidance orientation, where first you align the end plates of the vertebra, then you rotate the fluoroscope to bring your the uncinate process into posterior 1/3 or 1/4 distance from anterior to posterior lateral margin of the vertebra. And once you are there, then your target insertion point is 1 to 2 millimeter medial to the anterior margin of the uncinate process, which is somewhere here. You can see where the entry point is. And these are the lateral approaches. So in real life scenarios, you very rarely are dealing with just degenerative disc disease. Very rarely you are dealing with just the herniated disc, but most likely you are dealing with the disc that has almost everything. So again, do the discogram and plan your injection at least in 3 places, so you have understanding of how much volume you're going to need, and that will help you how much plasma you can use it, either for the PRP if you are using the Buffy-coat, or you are using the Buffy-coat for MS, the mesenchymal stem cell. This calculation of this volume will help you to calculate how much plasma you should mix it with your mesenchymal stem cells. And you can see the volumes are different for different levels and different injections. So this is what I have to offer today, and thank you for your attention.
Thank you, Dr. Wadon. That was fantastic. I learned a lot. I don't do a lot of intradiscal injections, but that's a fantastic talk. And I think that's excellent, because you hit all the bases regarding, what's the rationale for this and what do we inject. I have a couple of different questions from the audience. One question from my good friends down South America. He's asking actually a quick question regarding bone marrow, and he just wants to know, do you do bone marrow under sedation?
Yes, I do bone marrow aspiration always in sedation. And the reason is, when you do a very strong negative pressure aspiration, that could be very, very painful. So I always do a sedation. I have done under Versed, but that was not very, fun, because patient does react to it, and sometimes it moves around and makes difficult for you to do a proper aspiration. So my recommendation would be to do under IV sedation. Okay,
that's awesome. I want to point out real quick, you mentioned earlier about alpha-2 macroglobulin, and there are, I believe, Apex Biologics does make a protein concentrator, and so it's not as expensive as it used to be. The protein concentrator can create that for about $200.
Right.
Just to be aware of that. Question for you.
That's actually a very important point, George, because when I used to do a protein concentration, the kit will cost us $600. And, it's kind of, eventually it burdens patient, because when you spend more money, you're going to charge them more money. So I didn't use it, but, now since the, price has gone down, I might start, doing that again.
That's awesome. Question for you. You mentioned giving cefalozolin and gentamicin IV prior, or you said 20 minutes prior to your procedure. I just want to clarify for the audience, is that weight-based, like mgs per kg, or how do you quantify how much do you give someone?
So usually I gave 2 grams of NSAID, it's based on the milligram per kilogram. And 80 milligram, I usually give a standard dose, 80 milligram of gentamicin. There is a standard way to calculate based on the kidney function, but I don't really, as far as, as long as patient's kidney functions are okay, I use 2 grams of cefazolin and 80 milligram of gentamicin. Now, for a very long time, I used to use only cefazolin, but I've read a very important article written by our good friend, Doug Beal, and he has written a protocol for intradiscal injections and intravenous prophylaxis antibiotics, and he uses dual. I had a discussion with him, and I was convinced that using 2 antibiotics would be better than using 1.
Yeah, I think safety is important, especially when you're dealing with the spine.
Yeah.
There's a question from the audience about the needle and needle technique. Can you elaborate on that a little bit?
So the one of the risks that we have when you do single needle, meaning that going through the skin and to the disc, so single needle will carry those staph epi from the skin to the disc. To minimize that, the introducer is a larger needle which goes through the skin, and the needle actually that pierces the disc is not that pierces the skin. So needle in needle technique is to avoid the smaller needle that actually does the disc injections does not go through the normal skin bacteria.
Okay, so just to clarify, is it an 18 gauge or is it a 16, or what do you use?
So if you really ask for a needle in a needle discogram kit, you can get, introducer is different and the injector is different. That will cost you only $80. And if you use your regular in operating room 18 gauge injection that you use to draw your medications, and 22 gauge spinal needle, that will cost you 8 cents, and you can use it your own needle in needle kit.
Okay, that's awesome. That's good to know. Practical advice. What do you do? Is there any special aftercare for these types of patients after you do these intradiscal procedures?
So there is no really a specific aftercare is required regarding the procedure, because this procedure is not supposed to be very painful. There is some soreness, patient is advised to use some ice. They never really need to take any anti-inflammatory, they cannot take it, but they don't really require any kind of strong pain medication. In terms of any other rehabilitation, no, there is no really any specific rehabilitation required. Once in a while, if I dealt with the large herniated disc, then I would advise them to use a brace, and that is just to remind them that the bending forward and lifting weight might, produce reherniation. So I would advise them to use the brace for a couple of weeks, but that's only for if I have dealt with isolated herniated disc and not a typical degenerative disc.
A common question that people like to ask is it like, let's say you say it's a combined picture where you have nerve root impingement as well as the disc issue. When you inject into that disc and also around it, have you, in your experience, have you seen people have worsening radicular pain?
So if you are injecting for herniated disc, more likely than not, yes, there would be worsening of pain. But you have to have that particular scenario in your discussion, because if you don't want the patient may go home with feeling that I did something wrong. So that's important. Second, the good news is it does settle down in two days to mostly a week. So it doesn't last too long, and none of the patients really require any kind of treatment. I don't recall any patient that required a specific treatment for that, that increased radicular pain.
Thank you. One last thing, and I'm I'm pretty sure there isn't any literature out there, but I was listening to your talk and you brought up a really good point. I wonder, is there anything out there on, let's say someone does have a small focal defect in the annulus, and I guess I think you had mentioned about a surgeon who will inject the disc after it. I wonder if there's any difference that's been shown with reherniation rates now that people are injecting the disc with biologics.
So we still don't have any really good study out there. Dr. Hardell is working on that. If you recall, in our conference at New Jersey Pain Symposium, he presented some unpublished data about some 40 patients. Very, very encouraging results. He also was one of the lead author in basic science studies where he injected annular fibrous cells mixed with high density collagen and injected in a rabbit disc where the tear was artificially created. And they found that the tear actually healed faster and more complete resolution. But that was an animal study. And based on that, he has started now doing at Cornell. The studies is not published yet, but the so far unpublished results are very, very encouraging.
That's amazing. It sounds like a lot of great things come out of Cornell, huh,
Yes,
Professor?
Yes.
Well, thank you, everybody. That's the end of our questions. So I appreciate it for everybody who signed up. And thank you, Dr. Diwan, for your time and joining us this evening. Thank you for sharing your education, your experience, and most of all, your love with the world. So for those of you who don't know, I would highly recommend going out to New Jersey, New York Pain Symposium. It usually happens, I think, the first or second week.
First week of November.
First week of November. Thank you, everybody, for joining us. Have a great evening. Have a good evening, Dr. Diwan.
Thank you so much for the opportunity, and have a very good evening, George. You too.
Take care. Bye-bye.
Bye-bye.